Good evening. The subject is deploying a dose management strategy across multiple sites. Before I start, I'd like to disclose some information. I am the CEO of Red Protection Services SA in Greece and consultant of Affidea, a multinational medical services provider in 14 countries with specialization in diagnostic imaging and cancer treatment. The presentation objectives are to understand the challenges of implementing a dose management strategy in different locations and to learn more about practical examples. So, this dose management strategy I'm going to present is implemented according to the following numbers. We focused only on multi-slice CT with 6 detector rows and above. It's implemented in 6 countries, specifically Portugal, Poland, Romania, Hungary, Switzerland, and Greece. We have 36 CT sites. The CT systems are from 3 manufacturers. We have 12 different CT models. Out of the 36 CT sites, the 27 systems are with dose reduction algorithms. Regarding the teams and people involved, we have 53 radiologists and 70 radiographers. We focused on 11 anatomic areas. We created standardized 29 protocols. And the number of data we collect per month on average is from 22,000 examinations. The rationale behind the dose management strategy is, as already presented, that we need to assign dose management teams. We assessed the existing workflow and the dose awareness culture. We created a communication plan, we set goals and milestones, we fostered further the dose awareness culture, we used a dose tracking, monitoring, and analyzing software, and in practice, we justified the high dose examinations through alerts from the software, we standardized the quality control of the CT systems, the protocols and the practice. We optimized the CT operation, the protocols and the practice. We used reporting tools to see the process of our project. We are benchmarking the dose and to reach best practice throughout these sites' implementation. The teams, we have 4 different teams. We have the headquarters steering committee, which is the team that sets the strategy and communicates and controls and collaborates with the rest of the teams. We have a sponsor, as already said, resources are needed for such a project. We have the project leader, a medical doctor, a marketing leader, an IT leader, and a lean management leader. Below the steering committee, we have the country teams. Again, we have a project leader, a chief radiologist, a chief radiographer, and a chief medical physicist. The country team collaborates with the site teams, which are radiologists and radiographers. And of course, we have the third parties. Application specialists are involved, management teams are involved, and service providers. Regarding the goals that we set, we created a standardized city protocols list, which is 29 protocols. We set dose reference levels for these 29 protocols. These dose reference levels were set according to data published from different countries from 2010 onwards for these protocols. We set percentile targets for the standard use of the protocols, the justification of those alerts, the linking of the site protocols to our standard list in order to be able to compare the same things between the sites and the systems, and the compliance of the protocols to the dose reference levels. An important goal, the dose awareness culture. Very important also, the dose benchmarking that will help us set the organization's dose reference levels. Image quality testing. I will present how we test the image quality later. And the creation of the golden protocols in regard to the technical parameters and the clinical parameters. So the dose awareness culture, we started by assessing the culture in the organization in order to have a baseline. We are fostering the awareness culture through the automatic alerting system of the high dose examinations from the dose tracking software that we use. Every alert is justified, and there are monthly dose team meetings that discuss the alerts and their justifications, and very important, continuing education for both radiologists and radiographers to further improve the culture. The communication plan, we created communication material for 2 target groups, the medical centers and the medical practitioners and the patients, which means referring doctors, and of course patients need to be informed on issues as important as their examinations and dose they receive. The recorded CT dose quantities are the CTDI volume and the dose length product. Hopefully in the future we will have the SSDE and the effective dose. Unfortunately, this software is not compliant for the SSDE calculation for all the different CT systems. Regarding the dose tracking, monitoring, and analyzing, we connected the CT systems to a specific software. The software tools were used to link the site protocols to our standardized list by giving them an identification number. We set local dose reference levels in the software. We use the tools further to monitor and analyze the high dose alerts and to check the patient cumulative dose. And in order to optimize our protocols and move to dose reduction, we use data consolidation and other statistical analysis tools. In regard to standardization, we created standard operating procedures for the monthly and annual quality controls of the CT systems according to the EIA guidelines. We standardize our workflow with the help of the lean management team. And in regard to the CT protocols list, we set a list of parameters. Basically, the standardization is done according to the clinical indication and the number of series. But of course, we record a lot more other parameters that we will be using to further optimize our dose management strategy in the future, like the BMI. So we chose the most frequent protocols that account for 80% of the practice and 85% of the dose. Regarding optimization, we compared the dose values of the protocols to the dose reference levels that we have set on an organization level. We adjusted the protocol parameters accordingly, and for image quality testing, we are using anthropomorphic phantoms of the head, the abdomen, the thorax, and also blind studies, so we're interchanging examinations between the sites to make sure that the clinical image quality is appropriate for diagnosis. We created a very important report in collaboration with a dose tracking software vendor. This is the JSO report, the Justification, Standardization, and Optimization report, which records these parameters on a monthly and periodic basis. It records the percentage of high-dose examinations and the percentage of justified alerts, the percentage of performed examinations with standardized protocols, and the percentage of protocols optimized. There is a lot of data behind this overview that you saw before, but very important is the protocols compared to DRL's table, which through the colors we can visually, instantly see where we are. Green means that this specific protocol is below the dose reference levels that we have set for both DLP and CTDI. The orange means that either the DLP or the CTDI is above the dose reference level, and orange means that both CTDI and DLP are above the dose reference levels. Here we can also see the percentile difference for these values compared to the dose reference level set. So did we achieve dose reduction through this dose management strategy? Yes, we did. And here you see the different percentage of DLP reduction for the countries. We see differences in DLP reduction because some countries took part in this project earlier than others, and some countries needed less reduction because their practice was already more optimized. Also, in regard to the percentile of optimization that we achieved, we have almost for all countries above 50% of protocols that are below the dose reference levels that we have set. So there's still, of course, room for improvement. Regarding the dose benchmarking, for the different protocols, and for example, the sinus protocol that we have here, we are consolidating the data for all the different systems that we have. So according to the CT category, we find the protocol, the CT system that has the lowest CTDI volume and DLP. Also, we compare it to the dose reference levels that we have, and we check it further for image quality to see that this dose is appropriate for diagnosis. Challenges. There are, of course, a lot of challenges in this project, as you can understand, starting with the country legislation and national health system rules, the differences in the national mentalities and the CT dose perception, the differences in the dose culture between radiologists of different generations, the workload differences between private and public sector, making it more difficult due to higher workloads to be able to follow as quickly as other sites. Team spirit and collaboration, you can imagine how difficult it must be for all these groups to collaborate between them from different sites and from different countries. We managed to reach an agreement on the standardized CT protocols and the practices, which is an achievement, really. A challenge is the clinical and technical assessment of the protocols, and of course, the corrections to the parameters in order to reduce the dose. But you can see that from the participants' feedback, we're moving in the right way. So we have the review from a radiologist that says that the changes that we have made have very good image quality, and this is considered much better than the previous image protocols. And also the standardization will mean that a radiographer can work anywhere throughout the organization. To conclude, through our experience, we believe that with dedicated teams, continuing education, standardization, and a clear dose management strategy, dose tracking will indeed lead to dose reduction. Thank you very much.